Well, the normal range of potassium is from 3.5 to about 5 millimoles a liter or milliequivalents a liter. And I think there's been some controversy about what hyperkalemia is. Although the normal range, as I said, from 3.5 to 5, a lot of people don't pay attention until we get to 5.5, and some of my nephrology colleagues don't pay attention until it gets to about 6, and they don't worry. On the other hand, we've learned recently that maybe people should worry. We've had the opportunity to look at very large databases of over 100,000 people, and we've looked at the range of potassium in normal individuals and looked at the association of potassium to mortality. And then we've looked at it with various comorbidities, people with renal disease, people with heart failure, people who are elderly or diabetes. And if you're normal, you can tolerate a low potassium, around 3.5, 5, or even 5.5, with a very low incidence of mortality. But once you have comorbidities, such as renal disease and diabetes, and you're over 65, then the range narrows. And we've seen that if you have a potassium less than 4, you have a striking increase in mortality, or over 5. So once you have the comorbidities, we should be thinking about keeping the potassium in the range of 4 to 5. And as soon as you deviate either way, you have some difficulties. So there's a U-shaped relationship, and the nadir of that U is somewhere around 4.5, depending on the study. But a lot of my nephrology friends say they didn't worry and don't worry until they get to 6 or 5.5. But I think from the data that we've seen and from several studies, I think they should be worried, because even with CKD, chronic CKD, once you cross that 5 level, you're having an increased risk. So I think this is something that we haven't paid enough attention to on both ends, the low potassium as well as the high. Well, I think all of us know that hyperkalemia can be associated with increase in mortality, and there are also, of course, you can have motility changes of the GI tract and flaccid muscles, but it's mostly the fear of sudden death. And the implications of that have been pretty profound in cardiology, because a lot of cardiologists are frightened of causing hyperkalemia, and rightly so, and they've avoided the use of RAS inhibitors, and especially mineralocorticoid receptor antagonists. And they've avoided them, unfortunately, in places where the mineralocorticoid receptor antagonists have a class 1 indication and have been shown to reduce total mortality in patients with heart failure and a reduced ejection fraction. So that we find that people who have a guideline indication in heart failure and reduced ejection fraction, it's been very slow, the uptake of mineralocorticoid receptor antagonists. In the US, I think we're now maybe 50, 60% of people who should be getting it. In Europe, they're a little bit better, but still maybe it's 70%. In comparison, ACE inhibitors, beta blockers are probably about 90-something%. So there's still a long way to go, and that's a gap. And so we look for new drugs to reduce mortality, but maybe applying the drugs we have would give us a lot more today than waiting for things in the future that may or may never come. So what we have found is that people are not using mineralocorticoid receptor antagonists and often RAS inhibitors when you have concomitant renal disease, because obviously the risk factors for hyperkalemia are renal disease and diabetes and the use of multiple RAS inhibitors. And they have tended to not use them or use them at very low doses. And with MRAs, which I'm most familiar with and work with in heart failure, once they start, a high percentage of people discontinue them over the first several months as soon as they see a rise in potassium. So I understand that, and that's right, because you don't want to cause harm. On the other hand, you're exposing that patient to increased risk and mortality, and I think in the long run, hopefully with some of these newer agents, we can change all of that. Well, in the past, we've managed hyperkalemia by, first of all, avoiding drugs that cause it, and potassium supplements, things that affect renal function like NSAIDs, and we've put people on a low potassium diet, though that's easier said than done. A lot of us are not very well trained in nutrition and don't really know very much about which foods are rich in potassium, which are not, but I think that's something we should know. And even when we know it and tell our patients, it's very hard sometimes for patients to keep that, especially someone with heart failure who's on a low sodium diet and maybe has diabetes, already very restricted. So it's very hard. And a lot of the things that we tell them that are healthy are very rich in potassium. So that's a dilemma. So it's nice to say that someone should be on a low potassium diet, but very hard to do it. And when we've gotten into trouble there, obviously for acute hyperkalemia, we've had standard strategies and calcium gluconate, bicarbonate, glucose insulin, and we can also use dialysis. But for chronic hyperkalemia, for the most part, people have reduced the dose of a RAS inhibitor or stopped it, and as I said, exposed people to increased risk. And when they felt they couldn't do that or didn't want to do that, we've had drugs like SPS, which exchanges potassium for sodium, and that's been around for decades. I think all of us are familiar with that. But we've learned over the last several years that it's associated with increased risk. There's bowel necrosis, and it's very hard to take. Patients don't like to take it. I don't know whether any of you have taken it, but it's really difficult to take it over the long run. And I think that's really one of the great advances of these new agents that we have. They are much better tolerable than what we've had. So we have the opportunity for the first time since January, when Bertram became available, and we'll soon have ZS9 within a few months, I understand. We have new drugs that have been shown to be well tolerated and very effective in reducing serum potassium from hyperkalemic levels down to normal kalemic levels, and tolerable over, at least for Bertram, up to a year, and ZS9 studies are ongoing, and that will also be shown to be tolerable, very tolerable over a year with a very low incidence of GI side effects. Okay, so Bertram is a polymer that's taken orally and works primarily in the colon, and what it does is exchanges potassium for calcium and magnesium. It pulls potassium out of the gut out of the blood into the gut and binds it. It's not really binding it in the food, though it probably does a little bit, but it's really pulling, if you have hyperkalemia, it's pulling it out of the blood and bound to the polymer and exchanging, as I said, for calcium and magnesium. And ZS9 has a little different mechanism, also oral. It's a trap, and it traps potassium, and that exchanges potassium for sodium and hydrogen. And both of them supposedly are non-absorbed. Bertram has recently been approved, and the label says, and it is true, that it interferes with the absorption of several drugs, and the label for Bertram says you should wait for 6 hours before giving another drug. There have been recent studies that was based on in vitro data. There have been in vivo studies recently showing that many of the drugs thought that Bertram interfered with, they don't interfere with, but there are some that they do. But for the most part, I think 3 hours looks reasonable, but the label still says 6 hours, and we'll have to wait to see what the FDA says. We don't know yet about the label for ZS9 because it hasn't been approved. They may or may not have any drugs that interfere. I honestly don't know. But I would say both of them are well tolerated and effective, but there may be some differences. Well, I think both of these drugs, as I said, are effective, and I think we need a lot more studies. We know that they lower potassium, but I think we're not entirely comfortable yet that the strategy of using these drugs over the long term in people, let's say with heart failure, to maintain a RAS inhibitor is more effective than what we had yesterday when we dropped the dose or stopped it. And there are some people, in fact, that say some of the benefits of the mineralocorticoid receptor antagonists is because we raised potassium. And now when we're lowering potassium, maybe we're going to take that benefit away. I don't actually believe that's so, but we have to prove that. And I think we need the long-term studies to show that these agents really have an effect on outcomes, on mortality, and on hospitalization. And I think there may be differences between these drugs. ZS9 may have a faster action, onset of action. We're not sure because it's been studied under different circumstances than Bertram, so we'll have to see direct comparative studies, but that could be important. And as I mentioned, ZS9 exchanges potassium for sodium. Now, I mentioned about SPS, that exchanges potassium for sodium, and we know that SPS can be associated with edema. And we've seen in some of the early studies with ZS9 that there are episodes of edema that we haven't seen with Bertram, but they were at the higher doses, and we haven't had direct comparative studies. But I am a little concerned, and I'll tell you why. We know that both of these drugs effectively lower potassium, and when you lower potassium, both of these drugs also lower aldosterone levels, and one would anticipate when you lower aldosterone levels that you would lower blood pressure. And we've seen a consistent lowering of blood pressure with Bertram, but when we look at some of the studies with ZS9, we haven't seen that. So that raises at least the suspicion to me that there may be some absorption. But I think we really can't say that for sure until we directly compare these drugs. So at the bottom line at the moment is both of these drugs are a great advance from where we were just yesterday with SPS. Both of them are effective in lowering potassium. Both are relatively well tolerated. And I think for us as cardiologists and nephrologists as well, they're really going to be an advance because they're going to allow us, I hope, to use our mineralocorticoid receptor antagonists and our ACEs and ARBs much more effectively than we did in the past. But we need a lot more work.